This is Abigail Coleman, and I'm presenting my case study on JH for CSD 408. So a little background information. JH is a resident at St. James Rehabilitation and Healthcare Center. He's 70 years old, has 3 children and 5 grandchildren. He's a retired police officer and a veteran of the United States Navy, and he is extremely motivated, pleasant, and cooperative in regards to his treatment for dysphagia. So, upon admission to the facility, he had a diagnosis of hypovolemic shock, pneumonitis due to inhalation of food and vomit, adult failure to thrive, malignant neoplasm of the mandible, dysphagia of the oropharyngeal phase, chronic obstructive pulmonary disease, and acute kidney failure. So this is all information that was gathered through interview with JH and his wife. So basically in February of 2017, he was diagnosed with maxillary cancer. His treatment included radiation and a reconstructive palatal surgery. After the reconstructive surgery, JH was NPO while he was in the hospital for 1 month and fed via PEG tube. And as he was being discharged from the hospital, he and his wife reported that he received absolutely no evaluation or treatment for his dysphagia, which was absolutely crazy to me, considering he just had his whole palate reconstructed. At home, his wife blended all of his foods, and which she wasn't told to do. She basically came up with it on her own because he was having difficulty chewing and swallowing all of his food, so she just blended it. But he continued to consume thin liquids, which he, in hindsight, now that he has more information on dysphagia, reports that he was aspirating on almost everything, but he really didn't know that it was dysphagia. Then in March 2018, he was diagnosed with mandibular cancer, and he reported that he was maxed out on radiation treatment, and therefore his physician recommended chemotherapy. And when he started chemotherapy, he had a horrible reaction to it, which resulted in the hypovolemic shock that brought him back to the hospital. So when he was admitted to the hospital the second time, they completed an MBS, and that resulted in recommendations for loose blended puree and nectar thickened liquids. He was admitted to St. James Rehab Center on March 23rd, 2018, where we completed a clinical bedside exam, and we agreed with his MBS that puree and nectar thick was the most appropriate diet for him. So just a little bit of background on swallowing disorders and head and neck cancer. While treatment and surgery of head and neck cancer varies, research has found similar swallowing disorders in both chemo and radiation therapy. And those are weakness of the posterior motion of the base of the tongue, lack of coordination of swallowing phases, reduced elevation of the larynx and reduced laryngeal closure, and reduced epiglottic inversion. And other research shows that treatment for head and neck cancer comes with a long-term aspiration risk. So chronic dysphagia has been reported to occur in 12 to 69% of patients 6 to 9 months following treatment for head and neck cancer. In many of those cases, post-treatment aspiration is often silent because of a depressed cough reflex. And regardless of treatment, long-term aspiration continues to be a risk for patients that undergo treatment for head and neck cancer. So just a little bit of the results from the clinical bedside to kind of paint the picture of what JH looked like when we began therapy. So we entered the facility with aspiration precautions and on a puree diet with nectar thick liquids. He's a full code. His respiration was within functional limits. His dentition, his bottom teeth are all his, but he reported that his upper dentures no longer fit after the reconstructive surgery, so he's currently edentulous on the top. He was completely alert. He was 100% responsive to stimulation and strategies, and he was able to follow 3-step directions without assistance. So from the oral periph exam, overall it was considered a mild deficit. So his symmetry was impaired due to that surgery to reconstruct his palate. So that was on his left side. His facial sensation was impaired, and we suspect that that is secondary to his history of radiation therapy. His velar function was impaired. So basically, his velopharyngeal, he had some movement, but definitely he was not really getting any closure there. And that was, observed liquids coming up through his nose. And his speech was very hypernasal. There wasn't really a concern. He really wanted therapy to focus solely on dysphagia, but through his treatment of dysphagia and oral motor strengthening, his speech is currently much clearer, a lot less air is coming out through his nasal cavity. Saliva management was impaired. He had anterior spillage of saliva and liquids due to a weak labial closure. He was able to elicit a dry swallow, and for both coughing and throat clearing, he was able to do a volitional and reflexive. So for the clinical bedside, we determined that puree was, as I said, was the safest consistency for him. When we trialed mechanical soft, he had difficulty initiating the oral stage, decreased oral containment, delayed bolus formation, incomplete bolus formation, excessive mastication time, a munch chew, and reflexive throat clearing. And then for liquids, we didn't even trial thin. After we observed with nectar, he had some anterior spillage due to the inability to, a weak labial closure. So we cued him to use a throat clear after swallowing. He demonstrated good recall and a good understanding of the safe swallowing strategies and techniques that we introduced to him. And at that time, he began to be monitored and was provided with written guidelines for safe swallowing as well. So the characteristics that we saw at his clinical bedside were consistent with research in dysphagia with head and neck cancer. So what I found for research was that dysphagia may contribute to dehydration, which may eventually affect renal function, which did for JH. Reduced food intake and unfavorable dietary changes may lead to malnutrition and decreased resistance to infection. Prolonged feeding by a nasogastric feeding tube or PEG tube may be necessary, and this may contribute to sustained dysphagia because of muscle atrophy. Difficulties with speaking, eating, and drinking or drooling may affect emotional health and put patients and family members in social isolation. And muscle weakness because of atrophy and loss of sensation may also contribute to swallowing abnormalities. So every single one of these characteristics are consistent with how JH was presenting at his clinical bedside. So before I talk about the goals, I would like to say that I absolutely agree with all of them. JH was extremely aware, motivated, and is able to follow directions. He was just an excellent candidate for therapy. He was safe on the puree and nectar while using his safe swallowing strategies and was extremely motivated for a diet upgrade. So JH would benefit from more education on safe swallowing, oral motor exercises to increase muscle strength, coordination, and range of motion, as well as exercises to promote velopharyngeal closure and intraoral pressure. All right, so these are his goals. His long-term goal is that he will maintain adequate nutrition and hydration with optimum safety and efficiency of swallowing on PO intake without overt signs and symptoms of aspiration for the least restrictive diet. And he is absolutely maintaining them. He actually has put on 11 pounds since beginning therapy, which was huge. His family is so happy about it. And it's also helping him to be doing well in the other therapy that he's receiving, like PT and OT. His short-term goals: he will perform oral motor exercises, labial and lingual, for 12 out of 15 therapeutic attempts with 80% effectiveness for improved labial and lingual range of motion, muscle strength, and coordination, provided minimum cues for improved overall bolus management skills. So this goal is continued today. He's basically there, but he will still benefit from more strengthening exercises. The next goal is that he'll perform dysphagia exercises, the effortful swallow, and Masako for 15 out of 15 therapeutic attempts with minimum cues for improved airway protection given minimum cues, and this goal was met. The res will utilize safe swallowing strategies and techniques, alternating solids and liquids using a lingual sweep for 80% of the meal to improve safety of PO intake with minimum cues, which was absolutely met. It's been a pleasure working with JH, and I played a huge role in his therapeutic trial feedings for Fine Chopped, which is his current diet, and he's become so aware of using those strategies, and he'll say things like, "Oh, this is really dry. After I take a bite of this, I need to take a sip of liquid." So he's doing great. And he'll perform straw-sucking exercises for 12 out of 15 therapeutic attempts to improve velopharyngeal movement and intraoral pressure for overall improved swallowing ability. And as I said a little earlier, this has also improved. So he has reported that no liquids have been coming up through his nose, and his speech has become way clearer than it was before we started therapy. So, what we did in therapy. His oral motor exercises included lingual protrusions against resistance, retractions and lateralizations, labial protrusions and retractions, and a lip press. So we did lip presses on tongue depressors as well. His dysphagia exercises included the effortful swallow, Masako maneuver, and Mendelssohn maneuver. So the effortful swallow was to promote more clearance. Masako maneuver was to have more pharyngeal wall movement, and the Mendelssohn was for increased airway protection and closure. And then the safe swallowing techniques, he was cued to use a throat clear and a cough and re-swallow following each PO trial, and alternation of liquids and liquids and solids. And then intraoral pressure exercises, which was he would suck pudding through a straw and do buccal puffs. So JH now, he began therapy on 3/23/2018. Since therapy, he's met 3 out of his 4 short-term goals. He's been upgraded to fine chopped and thin liquids, and he's tolerating full meals without any signs and symptoms of aspiration. He's already talking about trialing regular, but not yet. He's gained 11 pounds. He's improved his hypernasal speech and speech intelligibility and saliva management. And he shows an increased sensory awareness and improved ability to utilize strategies outside of treatment. And those are my references. Thank you for listening.